Thank you for being with us today. Our last guest talk this year, this scholar year at the LSE Health Society. And I have the great honor to present Liz Thiebe as our guest today that will speak with us about her experience in leadership in healthcare. She has a strong record of operational and clinical management, leading change and managing very large, complex projects. Her clinical background and managerial skills set have enabled her to work successfully with both clinical and non-clinical leaders and staff to improve the quality of care delivered in Ireland, Portugal, Libya, Qatar, UK, and the US. So a lot of experience on implementing alternative cares, models of care, something that we strive and we study here and we try to evaluate. But then we also see the difference in the implementation. And so it becomes a work of many years of experience. And that's why we invited Liz, and I will leave the floor.
Can everybody hear me out there in virtual world? Is there a way to tell Hugo if people can hear me?
I'll let you know in once.
If not, I can hold the microphone.
Yes, they can.
Great.
Please.
Sit up in the front here, please. Okay, so first off, I want to say thank you to your president here, Hugo. The reason I'm going to say this is because we have been trying for probably 6 months to organize this. If there's ever, I think that's the longest time it's taken me to do something like this. And it's his perseverance that is the reason I'm here today. So we can, you know, for a virtual class. And it's an honor to be here. So what I'm going to do is talk with you about the implementation of innovation from a leadership position. And I'm going to call on my many years of experience, okay? And I think you're right, Hugo, you can have all the best policies in the world, and they can do nothing if you can't figure out how to excite people and implement them. And I've learned from lots of people, I have learned by doing, and some of that I'm going to share with you this afternoon. So I'm going to talk for maybe 20 minutes or so, and then what's most important for your own learning and your own discussion is to hear what you're thinking, what thoughts you have, what questions you might have, and then we can take the path that is in front of us, and who knows where we'll go, okay? So that's the game plan. I hope you're okay with that. So my background, just a little bit about my background. So I started life as a nurse in the late 1970s. So many of you guys weren't born yet, I'm pretty sure, which is fine. And I got my degrees, my nursing degree, and then my MBA in Massachusetts, in Boston, America. Worked as a nurse and then worked in successive promotions. And in America, if you have any Americans in the group, you'll know this, most hospitals in America are managed and run by doctors and nurses. There isn't a manager class of people, it's clinicians. And so my career pathway was not unusual for America, but is very unusual for some of the European countries like Portugal, for example. From that, I've done lots of things in terms of running organizations. I have done pretty much every job in a hospital, from being a volunteer to being a chief executive, and kind of everything in between. I also spent 5 years working at an organization here in London called the King's Fund. And if you're studying policy, you know about the King's Fund because there's a lot of fabulous minds and researchers that are there. There's also a group in the King's Fund, a department that's about developing leaders, leadership development. And that's the one that I led for 5 years. And it gave me a huge privilege to study with some of the best in the world who were leading innovation. So not only could I be a student, I could gather information that then I could apply myself. So that's the background I bring to you today. So I'm going to draw this presentation from a number of things. First, influencers in my past. And I'm going to name 2 people. And I'm going to give you some references about them. And I do this with pretty much every presentation I do, because it's my way of honoring the time they've given me to learn. I'm going to draw from my experience as a CEO in Qatar. And that will be a kind of a case study at the end of my presentation. And then where have I worked? Ireland, UK, Libya, Qatar, and the USA, and sometime in Portugal as well. Okay, so that's what I'm pulling from for today's lecture. So who are my 2 influencers? There are 2 men. One is Sven Olof Carlson, which is a fabulous Swedish name. And he ran the municipality called Jönköping Health System in Sweden. He's since retired, but at the time that I studied alongside him and lectured with him, he was running this organization that blended health and social care together, okay? In the UK, in America, in Portugal, social care sits in one bucket and healthcare sits in another bucket, right? In Sweden, that's not the case. So if you've studied the Swedish system, you'll know that it's one thing called care. In fact, when you go to Jönköping and you start talking about health or social care, they have no idea what you're talking about, because that's not how they see the world. And the fact that they brought it together helps them do all kinds of things that other countries can't. So they have a very low number of beds per head of population, because they figured out how to keep people healthier in their homes, how to discharge them quickly if they have to go to the hospital back home, how to keep them home instead of going to the hospital. They figured out all those structures you need to have in place to make that successful. So Sven is one of my people, and the other is Gary Kaplan. And if you've studied lean processes or value stream mapping, any of those techniques, there's a guy who used to run a health system in Seattle, Washington, called Virginia Mason. His name's Gary Kaplan. He's a doctor. Again, he was the CEO of the hospital, doctor, and he embodied the use of lean practices to streamline care, to remove waste and improve quality. He's now since retired, but he's working as a consultant, and I think he's doing something with Warwick University as well. So he spends time in this country from time to time. And I've got some of his references at the end, so if you want to learn more about these 2 people, there's places you can find. I find as an adult, and not as a student, but as an adult student, that I've been learning my entire career, and I hope to learn something from you guys today. I don't know what that's going to be. I hope I give you something that I will also look to get something. For me, there's this thing about lifelong learning, and you never know it all. And that's great, because you can always explore and find something new. That's the approach I've taken with my entire career, and it hasn't ended yet. Right? So I would just put a plug in for keep learning. Okay. So there are 4 things on this slide that are going to speak to us about what makes good leadership for innovation and improvement. And I think it's boiled down in my mind to these 4 things. One of them is about promoting a professional culture, okay, that supports teamwork, improvement, engagement. It's about relationships. Okay. I'm just going to plant these ideas in your mind, and then when I give you an example of Qatar, I'm going to illustrate how you actually do that, okay? So there's something about those relationships and getting people comfortable in those relationships to be able to share. The second thing to keep in mind is finding a common purpose, okay? Aligning the intrinsic and extrinsic motivators. Any of you in this room, clinicians, doctors, nurses? Yeah, what are you?
I'm a doctor of physiotherapy.
Physiotherapy.
General clinician.
General, okay.
Economics.
Economics, okay. So you're an outlier. I don't know who the rest of the people are.
And home too. Some doctors.
Some doctors, okay. So those of us that became clinicians when we first started, our first job, right? Why did we do that? For the glory, for the money, for the long hours, the lack of sleep, none of those things, right? Because there isn't much there. We did it because most of us care about people, right? So when I approach improvement and innovation, I approach it from how can we make things better for ourselves and for our patients? And that is an important internal driver for the workforce. What doesn't work are things like, how can we save money? People understand saving money, but they understand better how can we do things to improve people. And you can take it to money by saying, if we find ways to save money, we can then apply it to improve other things for our patients. But there's something about the difference between how accountants approach a money problem and how clinicians approach it. And I would urge you to think about appealing to kind of the reason that workforce decided on that profession. The third thing is finding a framework or a way to rapidly test up and scale up innovations, okay? There is nothing more disheartening than coming up with an idea and it taking a year for it to get off the ground. If that happened to me, I can assure you I wouldn't be that interested in coming up with another idea. But if you can create an organization or a structure that takes the idea and evaluates it and quickly assesses, yes, we're going to try it, and then try it, that rewards and values the person coming up with the idea. That makes sense? So it's how do you create that framework? Gary Kaplan had an amazing way of doing it, okay? If they had a system where if any staff member could email into a group email an idea, someone was assigned to assessing it within 24 hours, and it was either, yes, we're going to pursue it, or no, we're not. And then if it went to pilot, it was rapid and quick, and then it moved from there. That's incredibly engaging for people, especially the younger workforce in an organization who want to make a difference and might see something and they have an idea. That's what you need. You need a structure to do that. Sven did a similar thing in his organization. He created an induction, so all new employees had to go through a process. So they had to learn the basics of service improvement, and then he created a pathway for rapid assessment of ideas, same idea. So they both did something similar. They did it independently. I don't think they learned from each other. I learned from both of them, okay? So that's important. And then the last is using data and information to validate this change. Did this thing make an improvement? Are we measuring it? Is there a way to capture it? And not being afraid of data and looking for it, okay? So to me, those are the four kind of fundamentals as we think about what should we put in place when we're moving from policy idea into practice, into implementation. Okay. So this is about COVID. Were any of you working in a hospital during COVID 2020, 2021? Anyone? Hugo, you were? Anyone online? Put your hands up if anybody was. I don't see any hands up. Okay. It was tough, right? Where were you working?
In Lisbon.
In Lisbon, hospital?
Yes. Several hospitals doing rotation.
You were doing rotation, yeah. So during COVID, I'll tell you a quick digression of the story. I happened to be in Portugal in March of 2020 in the Algarve, enjoying a friend's home on the beach. And I got a call from a chief exec and chief nurse of a hospital here in the UK that I had worked with in the past. Where are you? Can you come back? We need you. We're exhausted. Our executive team is exhausted. We need a second executive team to keep us going, and we're looking for people. Can you come? So I left Portugal on the last flight out to Birmingham. And the next day I went up to, it was in the West Midlands, went up to the hospital and had a tour. Didn't know the hospital, but had a tour. My two friends worked there, so that was good. And I walked into the ICU, 30-bed ICU. And I've been a nurse for a long time. I've seen all kinds of things. I had never experienced the amount of chaos and worry and stress. I had never seen anything like it. It was incredible. So I went back to my two colleagues. I said, I know you want me to do this role. I'm suggesting you plunk me in the ICU because it needs support. It needs to give some boundaries and some help. That's where the help is needed. So for the next year or so, that's where I was. And I have to say the toll it took on experienced doctors and nurses who were used to saving people, and then they couldn't, was really profound. Because we didn't know how to treat people in the early days. We were thinking, oh, it's like pneumonia. We know how to treat, serious pneumonia, that's easy. But the treatments didn't work, right? So we had to learn through the rest of the world how to treat people. So the reason I want to talk about COVID is it had a profound impact on the workforce, myself included, and it's left some residuals that people are still working through. And it creates a real challenge. It also left some really, really good things, okay? And the first one I want to talk about is professional boundaries, okay? It did something around the world that we didn't know we could do like that quickly. It started to blur who could do what. Nurses were doing doctor things, doctor were doing nurse things. It was all hands on deck. Physiotherapists were doing, nurse things and some doctor things because they had a skill set, right? So we found a way to blur professional boundaries and also organizational boundaries. For me, to see an orthopedic surgeon emptying drains in the ICU of a patient was pretty amazing, right? So we changed organizational boundaries as well. No longer did that person only practice in the operating theater. They could practice elsewhere. And that created an amazing sense of camaraderie. It certainly saved lives. It also helped people see that they could move outside of their comfort zone and work with others in a different way. It was really profound. Second thing we learned was around the globe, and this speaks to sort of bigger health policy questions. How to treat people. Vaccines were developed instantaneously. We were sharing across countries. At the time that I was in the ICU, we were learning from the Italians because they had learned a lot more about what to do with these really, really sick patients. And they were sharing that quickly, So there was this kind of, I would call it underground kind of communication through lots of huge WhatsApp groups where people were saying, hey, try this, try this, try this, try this, clinician to clinician across country boundaries. Quite incredible. The vaccines were made quickly. They were distributed really quickly. They were shared across countries in ways that we need to find ways to continue to do that. It shouldn't only be during a scary pandemic. In the hospital that I was in, we discovered that all the barriers that we put in place to innovation evaporated. All of a sudden, the community services in this particular hospital were super important because guess what? That's the only place you could really take care of patients. You didn't want them coming into the hospital. So we needed to find ways to keep them out. So this hospital had developed something called a virtual ward, which is caring for patients in their homes without coming to the hospital. That was in a baby pilot phase, and quickly, because of the pandemic, it became mainstreamed. We found ways to do GP appointments. We were used to everyone trucking into the GP practice. Yep, they became virtual. And a lot of the GPs have continued that practice, which is fabulous. what we found, and I did a little study with some of the nurses and doctors post-COVID in this hospital to say, what do you want to keep? And the answer was, I want to keep that we don't have to go to all these stupid meetings that didn't help us. I want to keep that we could quickly make changes and get some funding to do it. I want to keep the importance of community services. Okay, so that speaks to the kind of barriers became overcome. We also found in the Midlands anyway that the sector boundary started to blur. So that health and social care boundary started to blur a little bit because care homes needed support. Were people from the hospital going into help with infection control practices. It was a way to keep people out of the hospital if they could be cared for there, etc. So there was a lot of blurring of that. And then last but not least is what I started with was the big impact on the workforce. And as a result, we have some newer nurses and doctors who have only practiced in the COVID days or shortly thereafter and don't know about what I considered sort of normal times, right? Because I haven't had that experience. And likewise, we have some people who were so upset, really traumatized by the COVID that they left the professions early. So we've got more of a workforce challenge, okay? But I wanted to just reflect on some of those because I think they're really important as you think about making things normal and fast tracking things and developing relationships. We know we can do it because we did it. Circumstances weren't great, but we can do it. Okay, so this is the Liz list, okay? This is the Liz list. And I'm going to reflect on these and then talk about them through the vision of, through the lens of Qatar, okay? I think when we talk about leadership, sometimes it's just this broad term that people throw around a lot. Oh, leadership did this. Well, what is leadership? Leadership's about us. It's about us as people. It's about us as relationships, in my view. My style of leadership lends itself really well to innovation and improvement. I think in part because I value being visible. I value giving of myself and engaging people. If we had 1, 2, 3, 4, 5, 6 people here, 1, 2, 3, 4, 5. Okay, 5 people here in this room, you would see what these 3 are seeing, which is I'm looking at their eyes. I'm constantly engaging, right? Because that's my style. It comes very naturally to me, but it's important. So there's something about you finding your own way to engage with people, and being visible is super important. When I first went to visit with Gary Kaplan in Seattle, Washington, he said, come on, we're going out. And every day he moved around the hospital, every day, not once a week, not once a month. That was his daily pattern. People could see him and talk to him and ask questions, and he could see with his own eyes what was going on, blah, 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 right? Being visible, super important. There's also something about knowing you. What is your mission? What is your commitment? Mine is mine. Gary has his, Sven has his. Hugo, you have yours. I don't know your name, you have yours, you have yours. We all have our own. And what's really important is that we're genuine and we reflect who we are. And none of us are perfect. We strive for perfection, but we're not there, right? So there's something about being open and honest when you make an error. There's something about being genuine about who you are and understanding what's driving you. And not everybody needs to do the things that I'm going to talk about because that's not who you are. It's figuring that out, and that takes time. The next one is about how you communicate with people. So when I was in Qatar, let me just fast forward to a couple of slides here. This was my workforce. Okay. That was my workforce. HMC is Hamad Medical Corporation, which is the public health provider for the country. Okay. That was my workforce. Incredibly diverse. Incredibly diverse. and one that came with different language skills and different cultures, okay? Now, you'll know this because I'm looking at a multinational group in front of me. I'm assuming we have similar things. You might take it for granted. When you're managing a workforce, where, and I was in this situation as CEO, English was a second language for everybody, except for a tiny group of people. And they didn't work in my hospital, okay? So English was a second language for my workforce. I did learn Arabic, so that was good and that was helpful. But not everybody else knew Arabic. So English was our common language. And I had to learn other ways to communicate. I had to watch people to see if what I said, did that work? Did that land? Maybe it didn't. I did an awful lot of drawing, because for me, having a pictorial was a helpful way to express what I was talking about and people understood it, okay? I'll give you an example. Do we have any people from England in your group here?
So Ireland.
Ireland, okay. So there's a term in this country called starter for 10. Has anyone heard that, starter for 10? I'll tell you what it means in the British context, okay? There is a television show called University Challenge, okay? If you ever watch it, it's on Monday nights at 8 o'clock or 8:30, something like that. And there's a host who asks questions, okay, to these student teams. And the first question is the first question, and you get 10 points with that question. So it's a starter for 10, okay? British people use that a lot, just to say, we're gonna start something. You know, what's your starter for 10? You know, it's that kind of, it's a colloquialism, it's a term. When I was in Qatar, a number of British people would use that term. And this audience had no idea what they were talking about. And you could see it. People were thinking, are we starting in 10 minutes? What does that mean that it's, what are we starting? And you could just see, and when you're learning a second language, or when it's not your first language, you spend an awful lot of time translating, don't you? I mean, I do. With Arabic, I'm constantly, it's slow. I hear, I translate, and then I can think, and then it comes out. But it's a slow synapse. So anytime you're putting up extra barriers like that, you're confusing people. The conversation has already moved on, and they're still trying to puzzle through what is the starter for 10. So I found it really important to do lots of drawing, okay, and lots of pictorials. And that way I was assuring myself that people understood what we were doing, especially if we were doing something new. In one instance, we were developing, implementing a new electronic patient record, and I had a very big hospital, about 600 beds in many different sites, okay? For the implementation, I created a heat map. And a heat map, yeah, but what is that, okay? It was a drawing. I did it with my own hand, okay, of blocks. So hospital, long-term care hospital was here, the psychiatric hospital was here, the main hospital's here, with different departments. And I just created a drawing that geographically placed the organizations. And then I started coloring it. So if there were a lot of critical care patients, or poor leadership, or poor engagement with doctors as you're going live with medical records, that creates some risk, right? So those would be red. And if there were areas where the leadership was really good and the doctor engagement was great and the patient acuity was low, that would be green. And you could look at it and do some planning. And then people understood, when we have extra resources, we're going to send it to the red areas because the green can manage. It was just a way to describe a plan without having it be lots of words on a chart. Okay, so I've gone through lots of detail around that one, but I wanted you to hear that. Okay. Liz's list. We're back to Liz's list. Okay, fourth item. Be interested, champion, be enthusiastic, coach people, show some, show some energy with your staff. Really important. If you want people to be excited about change, you've got to be excited yourself. Teamwork, make it visible. Show people what it looks like. Okay. So this is a really important one because people, when you're leading an organization, people watch you. They watch what you do. They watch what you don't do. I made it a point every day to walk the hospital with a very important to me person, my chief doctor, who was a Qatari surgeon. Okay, so if you know anything about Qatar, it's in the Middle East, very wealthy. Islam is the dominant religion. I was a woman leading an organization, which is unusual. But the fact that I was, I think, American and older made me okay, and I also learned Arabic. But I wasn't Qatari, and that's where the power base is, right? So Abdulaziz, my medical director, and I would physically walk the hospital together every day because he understood for me to be successful, I needed a bit of his power, and I knew to be successful, I needed a bit of his power, okay? People saw us as colleagues, they saw us together, and they understood that's what collegial stuff looks like because we were doing it together. Okay, so there's nothing better than showing people what that looks like. Being consistent is really important when you're trying to lead change. So if you have a system that's going to evaluate a new idea in 2 days, do it. Don't promise and don't deliver, right? Be consistent. So people depend on that. Engaging staff in safety and innovation agenda, and then modeling how to engage with families and patients as co-producers. I'm going to talk about this together because I think it's a good example that'll help you understand how I applied that concept in Qatar. Every single week, I would do a safety round. Dr. Abdulaziz, myself, and the chief nurse. And we would go to a different department every week, different department. Eventually we cycled back. So in a year, we probably went to the same place 3 times, which was good. And there was someone taking notes, okay? And here's a picture of what it looks like. The idea was to spend about a half an hour with whoever was in this department or the board. So here's an example here of a bunch of people standing around. It took about 30 minutes. And what we ended up doing, because it was the only way I could think to get people to talk, was that I had a magic wand. I went to a toy shop in Qatar and I bought a magic wand. So imagine this is it, okay? And the idea was, if you're holding the magic wand, you can make one wish to improve safety for staff or patients. And what would that be, okay? So each person would hold a wand, like you would hold it, and you would give your wish, and you would hold it, and you would give your wish, and you would hold it, and give your wish. And if you couldn't think of that wish, you just hand it to the next person. And maybe we'd come back again to you, And what I was doing was trying to get people to think about safety and improvement. I was trying to expose what the problems were in a culture that was not used to doing that. Okay? And invariably, it would work the same way. The first couple of people would say something like, oh, if only we could get food delivered at a different time, or something small, okay? And they would be watching how I reacted to it. And by the time we got maybe halfway through, maybe 2/3 of the way through, finally the big one would drop. Someone would be brave enough to talk about a serious issue. Okay, so it took time to develop that trust. You have to I had to let it happen I didn't push it. And then at some point, someone would say something big. And there's an example here that I'll describe, which is code blue. So I was on the high dependency unit. It's like a step down ICU one day. And we were going through this process. And it was about 20 minutes in. And someone said, I know what could make it better. If only, you know, our anesthesia team doesn't come when we call for code blue. That was huge for them to admit publicly that there was a problem. Because the culture was to shame people and criticize people rather than find a way through it. So I'm standing there with Dr. Abdulaziz, and we're both staying very calm and relaxed. Tell us more about this and what happened. It's a problem that they identified. They know it's a big deal. They want to save lives. They don't think it harmed any patient, but it could if they're delayed in coming. Okay. So we took it away. And what we found was in Qatar, there was a single switchboard that took all of the emergency calls into it. And then they had a series of bleeps, you know, those bleeps, beep, beep, and the phone calls would come in. But the system didn't work. And it didn't work in my hospital. It also didn't work in lots of other hospitals. So we uncovered a big issue. It took a few months to resolve, and then it got resolved, okay? These people told me about it. I wouldn't have known. How do you know? You can't be everywhere unless you hear about it, right? So for me, this is an example of leading by example. It's an example of leading by listening. It's an example of allowing people time and developing trust so that you are trusted to solve the problem. And then the final piece of this is once it's fixed, you go back to these people and you say, thank you very much. Here's what we found. You have saved the day. You were the heroes for raising it. Okay, so what are we doing? We're closing a loop. We're valuing the input, and we're making them aware that this is a culture for improvement and innovation. It's not a culture for being critical or discipline or the negative side of things, right? So that's an example there. When you do this and you're leading an organization, people think the CEO job is really hard. It can be the easiest job in the world if you listen, because people are telling you what the problem is. You don't have to find it. And they're telling you what the solution is. All you have to do is do it, right? It doesn't require a lot of brain cells here, okay? Okay, so that's Liz's list. And then the last one on Liz's list is knowing when to get out of the way. And what do I mean by that? What I mean by that is if you're leading well, you have to empower people around you. You can't do it yourself. And you have to delegate and you have to let people go. And you have to stand back and be okay if people fail because they're going to learn. And that takes a lot of bravery. Because most people that go into this, particularly if you're a nurse or a doctor, you know if you do it, it's going to be done really well because it's you. So you have to be able to let go. Now I've spent a lot of time learning how to do that. Okay. So let's talk about Qatar a little bit. So I shared a few of my things in my leadership journey, but I think from a public policy perspective and a population perspective, it's an interesting place, okay? This is a graph that looks at the size of the population, and there's different categories. On each graph, you'll see a blue side and a pink side. It's sexist, but that's what it is. The blue is the male population, and then the column going up is how old they are, okay, from 0 to 80. And the pink is the female, and you can see China has a different shape than Russia, than Brazil. OECD is probably Portugal, Western countries, and Qatar, right? So what's going on with Qatar? What is that pregnancy over there on the left-hand side of Qatar's slide? So that's men. What are they doing? They're building stadiums for the World Cup. They're building hospitals, they're building schools. Those are the workers immigrating into the country, okay? Young men, more than women. There's also something that's really unique about Qatar, which is there aren't a lot of old people. Why is that? What do you think? Here's why. So this shows us the population of Qatar and the percent of kind of who's who, right? Qataris are about 15%, about 10%, 10-15%. It's very low. Once you reach the age of 60, you go back to your home country. So the only people that are going to be 80, 70, 80 in that country are going to be Qataris. In this country, if you were to go to any emergency department in London, what would you find? Old people, by and large, with COPD, coronary artery disease, stroke, you know, the kinds of chronic illnesses, diabetes that you have when you've got complex people. You don't see that in Qatar. The emergency room is full of something else. It's the traumas related to construction work. Okay, so I had to do a lot of pivoting when I was there to change my mental model about who my patients were. That makes sense? So that made it a change, and a big one for me. I showed you this for my workforce, and I talked to you about what I did. Okay, so let's go back to my list of things. Okay. How did I do a professional culture? Well, I did that by being visible. I did that by bringing people together. I did that by showing people what teamwork looks like. I created a framework for rapidly improving things as fast as I could. Some things I could do really quickly, and some things I couldn't. And money was not a problem. It was the only job I've ever had that I didn't have a budget. Can you imagine that? I didn't have a budget. That's weird, isn't it? But I had other challenges, but that was not one of them. So I created the fastest framework I can. And data was a real problem for me because nothing was collected. So I had to do a lot of like ad hoc data collection, okay, to make it work. Okay, so that's my journey. That's my Qatar journey. Now I'm going to stop talking and see what questions or comments people have. And let's go to the people online first and see.
Henry asks, perhaps a naive question, given I don't have a clinical background, but I have worked within a corporate setting in the past where we have sought to implement a fail fast mentality to encourage innovation quickly. One major hurdle we face is that these innovations constitute a risk. A risk could have negative consequences. It strikes me that this risk would be even more pronounced in the clinical setting. What processes have been put in place in your experience to mitigate this risk in the clinical setting?
Really good point, okay? The best way to mitigate the risk, okay? It's not to pretend it's not, it doesn't exist, because they do, okay? Is to approach this as, let's try it for a day or a week or a month. And let's measure it. And let's watch it closely, okay? That gets you a long way. So Sven, Gary, and myself have taken that approach. And I'll give you a quick example of one that Gary did. The bird flu was a big issue about 10 years ago, I think, something like that. And in Seattle, they developed overnight a fast track, outdoor, underneath a tent, drive-through vaccination process, okay? The risk that was raised was, well, what if someone has a reaction to the vaccine and they're in their car and they're going to die? That was the perceived risk, okay? There was no evidence in the literature to support that, by the way. Okay, because most of the reactions people have come much later. They don't come in the first half an hour. And the prior practice was you'd have your injection, you'd sit in a waiting room so someone could watch you and see if you died, right? So basically it was not really a risk. So a couple things that I would suggest is one, you determine, is it really a risk or is it imagined? Where's the evidence to say it's a risk? Mitigate it if you can and start it as a pilot. Start it as we're going to try it. And that goes a long way actually with change. So if people think it's permanent and, oh, we're going to, no, you start it as a pilot and then you agree you're going to evaluate it publicly. And then you bring that evaluation back to the group that's overseeing it. And that works. There's always going to be risks. And there's always going to be people that I don't want to do it. But trying it for a little bit and seeing what happens works like a charm. And it's amazing that people have some experience and they realize it's not so bad. Do you have another question?
I have a question myself.
Okay.
In between all this that we talked about, because you mentioned leading innovation, and we see big problems. The first one that you mentioned is that we are also losing workforce, and we see most of that problem being assessing the working conditions, and so there goes the responsibility on the management and all the structure that is a hospital. We cannot teach that apparently, or can we in schools, in business schools, in training? We need people that are able to do those skills that you announced, and it's at the individual agency level. Are we doomed in healthcare?
No, we're not doomed, because I think there's two things we learned with COVID that tells us we're not doomed. One is we can change professional boundaries about who's allowed to do what, okay? So there are some places in the world that nurses do colonoscopy procedures. Not in Portugal, because I was talking with a bunch of Portuguese doctors recently, not the case. In the UK it's the case, okay? So if there's a shortage of gastroenterologists doing endoscopy procedures and you can train other people to do it, there you go. With COVID, we learned that we could do that and still be safe. We could do those kinds of things. Okay, so that's one hope, which is what are some of the other professions that we can change our laws? And in most countries, you have practice acts or ways that you're supposed to behave or guidance to protect the public good to make sure that competent people are taking care of you. Those need to be adapted, but they can be. Second, and I think this is the most profound one, actually, is that we need to keep moving on our journey from being paternalistic with our patients to recognizing that they can take care of themselves. Hand over some of our clinical power to others. And we don't do that particularly well, okay? We force people to come to care for us, to come to us for care, because that's our system. But let's think about a child who has chronic asthma. And they might get in trouble with a lung infection. Parents are going to know that's happening sooner because they know their child. But to get an antibiotic, guess what? They have to go to their GP to get it, or they have to go to the emergency room. Why? Are they not competent to make that decision? I bet they are. So this goes to that risk question. Could we give access to parents a prescription for antibiotics when they needed it without having to come to us and delay treatment? I think there's this untapped thing called the patient being able to take care of themselves that we haven't fully embraced. And we've got so many tools now. We've got so many virtual telemedicine ways and quick diagnostics that we can do to help people, kind of grasp some of that. And yes, you need to know how to use the technology. And yes, you need to be educated, but we've got ways to do that. So for me, I think that's important. I think too, we need to think about wellness of the people that are caring for us, ourselves. I'm talking about us as clinicians out there. With COVID, I think we learned how important our own ability, our own wellness is. And I think there's more emphasis now on paying attention to that. It's come on the back of people leaving the profession, which is unfortunate, quite frankly. But I think we need to shore that up and recognize that finding ways to take care of the workforce is equally as important as making sure they've got a good degree from a good university. That's how I'd answer that.
But precisely on the patient-centeredness tribe, you say that we haven't reached that yet. How do I formulate the question? We talk about health transformation, and that needs transition, but the transition then it's not adding some specific things on the way that we have the system that is medical centered, and so that patient-centeredness and how you say that the patient has to come to the system is the management idea to rechange the mindset and redesign healthcare through the patient journey, and that's the real value, and that will make the healthcare workforce more involved in making that partnership.
Yeah, and I think it's a long game. You know, you can't do this overnight, right? It's a long game. There's an organization in California. You've been out to UC Davis. I don't know if you saw Kaiser at all. Kaiser Permanente, big health maintenance organization, kind of innovative one out in California. Probably about 8 years ago or so, they started retraining their doctors. Okay, putting them through mandatory training to learn to use this more than this. Okay, to listen to what the patient is saying and wanting and needing rather than assuming. And so it's that whole kind of moving from, I have the information and I'll tell you to let's look at this together. And it's a skill set like any other. So some organizations are paying a lot of attention to it. Kaiser is worth looking at if you haven't studied it, because they're often on the forefront in the USA about how to do things a little bit differently when it comes to patient involvement. So, you know, it'd be great if we got to the point where we don't even talk about patient involvement. Of course we are, you know, it's about that. I think that's what makes healthcare so unique. It's different than making, you know, a car or an airplane, because the customer, it's your personal health. It can't be more important to anyone else but you, right? And so that connection and figuring out a way to leverage that connection is super important. So to me, that's the exciting bit, and that's where I would put my energy.
There's a big debate happening at the moment, isn't it? Like, you give a lot of responsibility to patients to take care of themselves, but ultimately they don't know everything about their care and about the needs, complexities of it. How much responsibility do you give to patients?
Exactly, and so and that's that whole risk question that Henry asked, like this risk question, how do you know when? And I think it's lots of baby steps. I don't think you just turn it on and it's fully mature. I think you've got to kind of work towards it. There was an interesting study done in, I can send you the link, Hugo, you can send it around, in Wenatchee, Washington State, okay? So this was on the back of, in the US, we used to have a good president called Barack Obama. You might have heard about the guy a while ago, but he invested heavily in funding for healthcare informatics, okay? And there are a number of pilots and studies done around the country, and there's an interesting one in Wenatchee, and I went out to see it because I was really curious to see how the hell they did this, okay? And what they wanted to do was reduce the frequent flyers coming into the emergency room. Again, older population, small community, and there were, you know, probably 100 patients who were using a lot of resources. And they segmented this group, and they took, one of the groups was people with congestive heart failure, okay? And these are people who can get sick really quickly if they have a blood volume increase because they might have had a diet change, and they might need more of a diuretic to take. It's that kind of thing. And what they did in this pilot was they put some monitoring equipment in the home, and every day the person had to engage with it. So they had to check their pulse oximetry, their blood pressure, heart rate, and their weight, okay, basic things. easy. They also added a nurse, the same nurse, phoning them every day and talking to them about how they're feeling, how's their diet, did they take the medication? And over time, they learned how to titrate their diuretic themselves because they had this nurse supporting them in the beginning. And then they learned, oh, if I had a big salty meal, I don't feel well the next day, I should take a little extra Lasix with diuretic. And they did it themselves, okay? That took months to get that confidence up. Okay? So it doesn't happen overnight, I guess is what I'm saying. There's an interesting study, and then they did a post. Well, what did it look like? Did they save money? Did they reduce hospital admissions? Yes, all of that. It's classic. And for me, the technology wasn't the answer. It was the technology plus the confidence that came out of a clinician giving them some time to learn how to do it. That's how you do it, I think.
Do you think like the NHS can support those kind of schemes? Like, do we
I
have
don't think you can afford not to. I mean, how can you afford not? It's sort of like climate change, folks, right? Can we afford to stop driving our cars? We can't afford to keep driving our cars because the world's imploding. So yeah, I think, but I think with most change, and I think if Gary was standing here and would be standing here, their success, it didn't happen. It happened over a career. Lots of incremental changes. And you know, for me, when you work in an organization that is really into change, it's infectious. And so you might start a program with COPD, and you might start one with diabetes, and you might do a different one with asthma. I'm making it up because that's your interest, right? And you're all moving in the same kind of direction. That's how you get people engaged in doing it. I think waiting for the government to say we must do this is probably, I'm much more bottom-up kind of organizer from that perspective. Yeah. Are we out of time?
I don't know if you have still 5 minutes since we started a little bit later. I still have actually 2 questions that may be interesting. One of them is.
And then your colleagues might have questions.
No,
too.
yeah, exactly. Please.
Let's see if you have a question first.
2 more.
No, please. So I'll do one.
You do one.
I'll do one. So we need precisely to bring the knowledge of the front line to who is doing policy making, who is doing research. There's a distance between and even management from who knows what are the problems and how they adapt daily, and then the patient and the staff are the ones that are able to find the solutions, and then the others, of course, find the resources that help to put those in places. How can we scale this frontline research and connection with the upper level, in your opinion?
Yeah, so that's getting the ear of policymakers, right?
But we also need to give channels for the staff, for example, to communicate and to know that they are heard.
So it's kind of 2 ways. On a small level, I've worked in an organization in Massachusetts where we did just that. So we took all the executives every week, and we said before our exec team meeting, we all had to go and talk to 3 patients. Okay, and come back. It takes 15 minutes, very short. The chief financial officer was super uncomfortable with that. Someone like me, any opportunity to talk to a patient is gold dust. For him, he was afraid, okay? He didn't know what to say. He was an accountant. He sat behind an Excel spreadsheet, basically. That was his life. Very comfortable there, not comfortable there. So we helped him. I said, come on with me. I'm going to pretend you're him right now, okay? Come on with me. We're going to take some newspapers. This is when we had lots of newspapers. And we're going to go talk to patients. And we'll walk in. Hi, Mrs. So-and-so. Here's a newspaper. How's your care? What are you thinking? How is your health? Have a conversation. So it took time to kind of get, so bringing policymakers into the environment, whether it's in the community, a home, a hospital, whatever, is an incredibly important thing, and doing that in a routine way is a really good thing to do. So they see it with their own eyes, they experience it. Super, super, super helpful. And it starts to break down barriers. And for this accountant, no longer was he seeing the patient numbers as numbers. He could see people's images because he had been around them. When you're a clinician, you take that for granted, you know, I do. I love talking to patients because that's, you know, and I see them as just people. And I see numbers in a different way. And so I think there's something about how do we engage. It's a two-way street. How do we engage from here and how do we engage from here and get ideas bubbling up. I think in the NHS, we don't do enough about sharing fabulous practice. My observation is, and I've worked with hospitals throughout this country, lots of them, there's a lot of really good stuff happening and you would never know it because people keep it to themselves. I don't know if that's a British thing of not wanting to say, hey, look at me, but I think there is something about how do we share really good practice and get the word out beyond just the NHS world through the country, because there's some amazing stuff going on. And that's what keeps me motivated, quite frankly, when I see it, because it's good, you know. So it's getting people energized, getting people writing about it, you know. Your organization, your health society is a super important one because you can help bring that kind of stuff together if you value it. So we all have a different kind of role in this, I would suggest, and certainly you have one as well. Yeah. Does that answer some of it?
Yes, definitely. In the perspective of management, on the perspective of policy and research and social side, it's definitely tricky, and but that's why people are thinking about that. But it needs to start at the personal level. That's definitely that's great.
It always does.
Of course,
it always comes back to relationships.
Yeah.
Right now, I'm chair of a charity in Warwickshire. I live up in Warwickshire. It's a sight loss charity, small. I'm trying to model what it looks like to bring health, social care, and the charity sector together. So I'm taking the baby step of trying to meet them all together in our space so that they can talk to each other, because they don't. So the people that are caring about, you know, people with vision loss in the home and the people in the hospital and our charity, we don't know each other. There's a magical thing that can happen when we're all together. So I'm trying to model that. Once it's successful, I'll be writing about it and sharing it with others to show people that you could do these kinds of things. I think it's lots of baby steps, and I think it's personal responsibility, Hugo, quite frankly.
And there's ways to do that, to organize that involvement for improvement, because on some countries we have patient association. Personally, I see those that then they're not representing the patients, they're representing the interests of the association.
Yes.
Well, we have in other countries, and I think you know better, that these Esther project in Sweden, where they train the patients, and they should train also the staff to be involved on the innovation and improvement process.
Yeah, and not after the fact. So some places you see a team will come up with a solution and then share it with the patient. What do you think? Oh, that's not good enough.
Well,
they should be together designing, together learning from each other. That's where the magic is, I think. Yeah. Okay, what's your question or comment?
My question was, you know how you're talking about how you ask the team any feedback and how to improve things. We're really interested in like measuring health system performance. Have you seen the system? There was an incident where I think with cardiology, and then there were doctors who weren't reporting the right outcomes, and that changed the way they did the outcome measurement performance. In the different hospitals that you've worked at and seen, is there a system that's worked really well where you can measure the performance, good accountability?
Yeah, there are, and the best ones are, again, you're going to hear this theme from me because I'm really a community activist in my heart. Okay, it comes from the bottom up. So you ask your cardiologist, if you're giving good care, what does it look like? And then that tells you what you're going to measure. That's where you start, okay? And then you find ways to get data that's good. And also a period to share the data, and if it's not good, people can correct it for you. So you're agreeing that you have a data set that you can rely on, okay? And particularly when you've got poor performers, so you could have 10 cardiologists in one that's got some bad outcomes by whatever measures you come up with. And oftentimes the answer you get when you present the data to that cardiologist is, oh, data's wrong, or I'm special, my patients are sicker. So you risk adjust it, right? So you come up with data that takes those arguments away. And then you can really look at performance. Yeah, I think, I mean, I worked in many, many hospitals, okay? In every place I've worked, you know who the good doctors are and the good nurses, and you know who the ones you don't want caring for you. You know those people because you work with them. So it's finding a way to kind of expose that and help them improve by looking at the same data sets. It's not as successful if someone from above says, here are the 10 things we're going to measure, and we're going to control the measurements. It's better if it's built this way. That's my experience with it, yeah. And you can frame it, you know, you can have your first meeting with, here's some data sets I'm thinking about, what do you think, what am I missing, you know, so you can you know, give it some structure, but always ask before it's agreed, I think, yeah. Because if you were that person, wouldn't you want to have input? Of course you would, you know, I would, yeah. And do you have a comment or question? You're okay, okay, no comment or questions, okay. Anything else from online, Hugo?
So I don't know if there's any other questions online, please, meanwhile, if you want to let us know. If no, I think because we're already a little bit over the time, I'll wrap up. Thank you for that perspective, because we need it.
And thank you for you people online and all of your colleagues. So this is recorded for people to watch. And so my plea to you is stay organized. The world needs you more than ever. We have a climate crisis sitting out here that has public health, massive public health implications. We didn't talk about that today, but it requires relationships of people from different places to kind of come together and know each other to be able to come together. You've got that foundation. I would hold on to it and push it. And thank you for today. And the three of you have been delightful. And all of you.